So yesterday actually we have dealt with the major one of the major halves of the microbiology, that is general bacteriology and the systematic bacteriology. So it's now we'll move on to our other most important topics like virology, then mycology and some applied microbiology. So as you are all aware, this microbiology, as madam has rightly said, this is a subject which actually overlaps many other clinical specialities. Even though it is coming under allied specialty, will overlap many cases of medicine, general medicine, pediatrics, then orthopedics, whether if it is surgery, gynae, all the departments will have to go through this subject only. So we will start with the topics today. It's actually a little more lengthier session. I will try to restrict it by around 9 o'clock, but some more slides are there. So I think it will be a wonderful session for you. So first of all, we can start with the first question. That is, what is the thing which actually stimulates interferon beta? Anybody with any answers? Yes, it is the viral infection. So there are three different types of interferons, mainly interferon alpha, beta, and gamma. So where do you hear this terminology interferon gamma? Yesterday I have discussed about that interferon gamma in one particular test which is done for a bacterial pathogen. Does anybody recollect it? Wherein I have shown one picture of a satellite as along with one CFL lamp. Yes, it is the tuberculosis where we will use gene expert or quantiferon TB gold, where it will go and detect the interferon gamma release, or which is actually a byproduct which is occurring in a type 4 hypersensitivity reaction. So whenever there is any viral infection, it is not only restricted to the interferon beta, but also the interferon alpha, and alpha will also be stimulated and their production will be increased. But interferon gamma is a thing which is actually distant apart from, little bit different from the viral infection part. Rather, it is due to this mainly seen in case of delay type of hypersensitivity reaction. Okay, now coming to the next question, viral quantification is done by which of the following methods? Egg inoculation, hemadsorption, plaque assay, and electron microscope. Anyone? It's actually plaque assay, not egg inoculation. Egg inoculation is a procedure which I will be coming to you after in the coming upcoming slides, where I will show one diagram of what is actually happening in an egg inoculation, what is it used for. So it cannot be used for viral quantification. The terminology viral quantification simply means that it's actually the estimation of number of viruses in a particular sample. So quantification is usually done using plaque assay. This is an example of a plaque assay. I hope you can see the image, wherein we use different cell line plates where we'll inoculate with the sample and we will approximately titer. It is just similar to that of a microbrose dilution, which is done for a bacterial pathogen. So extensive or elaborate learning of this thing is actually not required from your point of level, but only question which is being asked is the method by which the viral quantification can be done. Another option, if you are given the correct answer can be given as a real-time PCR, where yesterday I have already dealt with the type mechanism of polymerase chain reaction. I forgot to mention one thing. Every time you will hear about the terminology RT-PCR, where capital R is capital, T is capital, and PCR is also capital. But I want to create a special emphasis whenever you are seeing RT-PCR, instead of capital R and capital T, if it is small letter and small letter T, small letter R and small letter T, then that simply implies that it is standing for real-time PCR and not RT-PCR, capital letter RT-PCR, where it stands for reverse transcriptase PCR. So ideally, the tests which we are usually performing for many detection of SARS coronavirus 2 is actually to be written as small letter R, small letter T, capital letter R, capital letter T, PCR. Okay, so RT, RT-PCR, that is real-time reverse transcriptase PCR. So that can also be used for viral quantification. It's especially done in case of hepatitis B virus quantification, where HBV DNA load is actually very important to be detected for a treatment purpose of a patient. Okay, so another possible answer other than plaque assay is RT-PCR, especially quantitative RT-PCR. Yes, it actually looks like slight flocculation, but slight flocculation is little bit different, as Dr. Roshni has rightly pointed out. This is a test which actually is being done on a culture as a cell line culture, wherein we are all aware about the fact that these viruses will usually only grow on grow as an intracellular thing, because it cannot flourish on an extracellular medium, just like bacteria which grows on a agar plate. So this is little bit different from flocculation, where flocculation there is nothing, no cell line based things are used. It's only plain liquid suspension of organisms, wherein you can either look for can be organisms or can be the target antigen antibody reaction. So there it is actually antigen antibody reaction occurring. Here it is a neutralization based assay between an virus infected cells and the corresponding antibody. So that is the thing which is actually happening in the viral quantification using plaque assay. I hope you are clear with the concept of flocculation as well as the viral quantification by plaque assay. So this is an image of a suckling mice. So suckling mice means it's the newborn, fresh newborn mice, which is actually within a period of time of 48 hours from the time of birth. So anybody know which is used for identification of which of the above mentioned viruses? Coxsackie, herpes, pox, or adenovirus? Any idea? Yes, it is actually Coxsackie virus. Coxsackie virus, especially Coxsackie virus A24, this can be responsible for creating acute hemorrhagic conjunctivitis along with enterovirus 70, which is an actually question which is coming in the upcoming slides. So I will discuss about that in that particular area. Herpes virus, pox viridae, and adenovirus. These are all upcoming slides. I will go through then each of these viruses in that particular section. Okay, now human fibroblast cell line, it is used for the cultivation of which of the virus? Adenovirus, polio, CMV, or measles virus? Anybody? Yes, it is the cytomegalovirus. Cytomegalovirus is a virus which actually it's more interested in growing in fibroblast cell lines. So because its the area where this cytomegalovirus flourishes well is in the fibroblast. So you can simply make use of these fibroblast cell lines. This is actually the way by which we are maintaining different cell lines. So cell lines means actually it is extracted cells which can be used to make these organisms or make these viruses to be grown in an extracellular, in an in vitro culture plate, that is outside a human body or any animal live tissue. Okay, so where we'll take this is a shown, this is actually a liver pot which is being taken, or just imagine any normal tissue. If we are taking and doing a trypsinization, that is the breaking down of this protein content, and enzymatic digestion is then done, and we will, just like how we take care of a newborn baby, we will give it nutrients and also take away all the toxic materials which are being produced. So it's a very cumbersome procedure, and it is laborious too. So this cannot be done in usual laboratories. We will always have to go for higher tier laboratories where there are actually adequate manpower, so that they can perform these kind of assays. So where will with these continuous cell lines, we will add the test organism, whether it can be some specimens like sputum specimen, saliva specimen, or any other aspirates from a genital ulcer, like that, different, as it will go on like the type of condition which the clinician is facing, and then we will look for how the organisms actually interact back with the cell line. There can be different types of interaction. Sometimes it can cause the ballooning of the organism as in herpes viridae, and sometimes it can cause complete necrosis of that particular cell line. So based upon that, the outcome which is actually happening in the cell line, we can identify what is the type of virus which is growing in that particular, or which is present in that particular sample. Okay. So coming to the next important thing, this is usually an examiner's favorite thing. I will give examples of few viral inclusion body in the coming another slide. But anybody? Yes, it is actually the summum of bodies. Summum of bodies you might have heard back in the pathology session or in your second year MBBS, where these are actually calcium deposition or due to a hypercalcemia in a patient. So it is something different from inclusion body. Inclusion bodies are actually different types of collections intracellularly. It can either be intracytoplasmic or it can be intracellular nuclear also. So we are having different classification about which I will be dealing about molluscum contagiosum, nigri bodies, Bollinger bodies also I will come. Okay. So now next question, which of the following is not an RNA virus? Anybody? No, it's not vesicular stomatitis virus. Here you can have to note it is actually simian 40. It's not an commonly heard virus, but this was a question which was asked back in the NEET examination. So the thing which you have to remember in your life is there are not many viruses which are DNA in nature. All majority of viruses are actually RNA viruses. Only exceptions for these DNA viruses include herpes viridae family. You can remember it as a small mnemonic. It's actually difficult to remember, but still you have to mug up it for the examination, because this is another examiner's favorite area. They will ask an RNA virus or a DNA virus. So you can remember it as HHP PAP. HHP PAP, just like pap smear, HHP PAP. Okay, so H stands for Hepatna viridae. Then under Hepatna will the hepatitis B virus come. Then another H is actually for herpes viridae. Then P is for Papua viridae, then another P is for parvoviridae, then A for adenoviridae, and P for papilloma viruses, papilloma group of viruses. Okay, so these are the usual DNA viruses. It's very, very important because all the rest of the things are RNA viruses, especially the SARS-CoV-2, which I have discussed about in detail while during the polymerase chain reaction component. So the simian 40 virus, it is actually coming under the polyoma group of viruses, which is under the papoviridae. Okay, so simian 40 is hence not an RNA virus. Instead, it is a DNA virus. This Ebola is actually, you might have heard about it. It is a problematic thing back in Democratic Republic of Congo, where it is causing Ebola hemorrhagic fever. It is very deadly, and there is particularly one thing I have to emphasize. I had created one mistake back in my post-graduation degree, and I was fired my HOD, because usually many of time we will see that the structure or the size of viruses is usually around lying between 70 to 200. But I feel it was very difficult to mug up what is the proper size of many viruses. So I studied just like that usually they range from 70 to 200 for my postgraduate model examination. What I did was actually simply wrote some rough estimate of any viruses. But one question asked was Ebola virus. Unfortunately, I was unaware about the shape of that Ebola virus by that point of time. So I just simply bluffed it as around 150 nanometers or so. But unfortunately, this is a long filamentous virus, and the mistake, it was immediately picked up by my HOD because it is a lengthy virus. I mean, virus which is actually elongated in nature. So whenever you see this kind of diagram, always remember it is a Ebola virus which is actually long filamentous in nature, and it can even extend in length above about more than 1000 nanometers in size. So rabies virus, it is actually another virus which is having a similar bullet-shaped appearance. It's also a previously asked question. Rabies virus appears as a bullet-shaped virus. Vesicular stomatitis virus, there is nothing peculiar in its structure. So now next question about interferon. What is true about interferon? Viral protein, virus specific thing, a host protein inactivated by a nucleases. Any idea? It is actually a host protein. It is a host protein, not a thing which is actually produced by the viruses per se. It is a reaction which I have initially told interferon alpha, beta, gamma. Even all these three are actually produced by our human body, which are actually coming under a classification of cytokines. So there are different cytokines. It is a vast topic. The time will not permit me to go through that particular topic, but remember interferon is a thing which is actually being produced by host tissue. Okay. So in which of the following tests viral load done by RT-PCR, or which of the following conditions viral load done by RT-PCR is of no role in the investigative procedures? First option is person with hepatitis B on tenofovir therapy. Second is HSV causing temporal encephalitis. BK virus in a patient of allograft renal transplant. CME PCR in blood of patient of liver transplant. Any idea? So, it was actually a previous AIMS question, but I found this thing to be really interesting. Anybody who has seen some patients with encephalitis back in your clinical life, you might get an answer about this. I've already given the clue. Yes, it is actually HSV causing temporal encephalitis. So in all other condition, I have told hepatitis B for therapy. I have earlier mentioned that we require real-time PCR for quantification. So it is applicable in case of hepatitis B therapy. Then in BK virus for allograft renal transplant also we require quantification. CMV is actually detected by quantitative DNA PCR, especially in blood or sometimes even in urine sample. But in HSV, there is no point in actually learning about getting an idea about what is a load of HSV. Anyways, it is actually encephalitis, and HSV, if you are getting a diagnosis, it is a type of viral encephalitis wherein you can use acyclovir for treatment. For many of the viral pathogens, this antiviral treatments are not so effective, but this is a case where you can go for acyclovir treatment, and there is good amount of response for treatment with acyclovir. Okay. So any idea about this thing? Herpes zoster oticus. You can see some vesicular lesions, which are there in the pinna, ear pinna, just anterior to tragus, etc. So what is the causative agent? Yes, it is actually herpes virus 3, which is previously called as varicella zoster virus. Nowadays, the naming of this herpes viruses has been changed. There was this previous, it has been recently changed into herpes virus. Human herpes virus from 1 to 8. So one HSV1, previous HSV1 and 2 is now being reclassified as HSV1 and HSV2. Varicella zoster with HSV3, Epstein-Barr virus with HSV4, then cytomegalovirus with HSV5, then HSV6 and 7 are the named as such itself, and HSV8 is actually Kaposi sarcoma associated herpes virus. Okay. So now coming to the next question, a patient presented with a vesicle on the skin and the microscopy of Sang smear. The term Sang smear can give the point for you. Showed giant cells. Causative agent is. Yes, it is actually the same varicella zoster itself. Varicella zoster is the lesion where you can see this giant cell, multinucleate giant cells in the case of Sang smear. Sang smear is just a smear which is actually made using the vesicular fluid, and we will stain it using Giemsa stains. Okay. Or any other Romanowski stain. Now, coming to next question, an 8-day-old neonate with microcephaly and periventricular calcification is suspected to have CMV. So he can appreciate periventricular calcifications. That is, this is the, I hope you can see the cursor. So this is the ventricles, lateral ventricles, and you can see in the lateral aspect of the lateral ventricle, there is calcification. Okay, so what is the best sample? Yes, it is actually urine, not CSF. For detection of CMV, I mean CNV involvement in any case of ventriculitis, it is better you have to go with urine sample rather than CSF. It's always better if you can go for this so-called urine sample. Okay. So next, this is another inclusion body. Here you can see a typical owl side type of inclusion bodies. So which is, it is seen in which type of infection? Anybody? Yes, it is seen in cytomegalovirus. So I will discuss about the inclusion bodies right now here. So you can see I have told there are different inclusion bodies, intracytoplasmic, intranuclear, then both combination of an intracytoplasmic and intranuclear. So it's very important among this thing is the Negri body. About this, I will be dealing with another question. So it's seen in, say, Negri body seen in post-mortem specimens, especially in brain biopsy, whereas in case of hippocampal or cerebellar region, if you are taking brain biopsy and staining it with the histopathological stains, you can see intracytoplasmic eosinophilic inclusion bodies, which are typical of rabies virus, and it is pathognomic. If you are seeing such a kind of lesion or inclusion body, it is confirmatory for rabies by diagnosis. But one disadvantage is that it can only be done in case of a post-mortem patient. So for routine antemortem diagnosis, it's not always wise to take a brain biopsy, because a patient already might be in a severe state and we cannot go for a brain biopsy at that particular time. Then other bodies of other intracytoplasmic inclusion bodies include passion body, which is seen in variola virus. Then Guarneri bodies in vaccinia. I can give you clue. One another body is Bollinger body, which is actually used, which is usually seen in case of foulpox virus. It's also a repeatedly asked question. You can remember it as a foul ball. Okay, a ball which is actually thrown as a foul. Okay, foul ball. Bollinger body is seen in foul ball, foulpox virus. Okay. So molluscum bodies, as the name suggests itself, you can identify it is in molluscum contagiosum virus, about which also I will be dealing later. Then perinuclear cytoplasmic body, Rio virus. So among these most important examiners' favorite are Negri bodies and Negri bodies, Guarneri body, and Bollinger bodies. Okay. So and then in intranuclear inclusion bodies, you are having two different types, that is Cowdrey type A inhibition, inclusion body and Cowdrey type B. So among Cowdrey type A comes the Taurus body, which is also another examiner's favorite. I used to remember it like the Thor in the DC comics. So you remember that Thor is actually king who is sitting on a yellow throne. If you are remembering like that, you will be able to correlate it back. So Thor, who is sitting on a yellow or golden throne. So Taurus body is seen in case of yellow fever virus. Then Lipschultz body is seen in case of herpes simplex virus. Then Cowdrey type B inclusion in case of polio and adenovirus. These are least asked. But these two things are very important. Intracytoplasmic and both intracytoplasmic and intranuclear, that is seen in, as in the image, that is owl eye inclusion body seen in case of cytomegalovirus, and measles virus, wherein you will see Warthin fingerly in type of inclusion body. I will type about that. It's not written in the image. Warthin fingerly bodies. Okay. So these are the commonly asked inclusion body. Many times I see this is a repeatedly asked question. Inclusion body is a high yielding topic. If you are learning this thing, there is a high chance you can score one question. Okay, so don't avoid learning this inclusion body. If you are finding it to be difficult, try to correlate in a way that you can recollect it very quickly, because you are usually dealing with an MCQ type question. So try to learn in a fashion that you can crack the examination simply by making small sort of mnemonics, whether it is some sort of visualization or some sort of stories which you have settled in your life. Make some correlation. That I often felt microbiology, everybody finds it very difficult in order to correlate. They will go out blank when you are sitting in front of an examination or question paper. So try to make some sort of connections. The rest of the thing your brain will do. Okay. So make some connections so that you don't go out blank. Okay. Now, next question, Paul Bunnell test. It is actually done for which of the pathogen? Yes, it is actually Epstein-Barr virus. So it is a test by which we will use IgM antibody along with sheep RBC so that you can detect the presence of IgM antibody in the blood of the patient against this Epstein-Barr virus, which is combining with the sheep RBC, and finally ending up as an agglutination reaction. So it is an agglutination reaction, so you can visualize it back with your naked eye. Whereas remember what I have told yesterday, precipitation reaction, you cannot see anything using your naked eye. But this test is actually no more used because there are good amount of other tests which can be used for diagnosis of Epstein-Barr viral infection. So this is another question. Newborn baby having a characteristic rash, and on examination, eyes showed white nuclear cataracts and a continuous murmur is being auscultated. So what family does this virus belong to? So anybody, what is this particular clinical condition? Yes, it is actually the congenital rubella syndrome, wherein you can see different kinds of rashes, involvement of multi-system, involvement of this ophthalmological wing, then cardiac and skin manifestation. There can also be sensory neural hearing loss. So rubella virus was previously being classified under the Taugaviridae family, but it has been recently shifted back to Matonaviridae. It's a new family. Okay, so remember about that. It is coming back in the Matonaviridae. So this is another question which I have discussed some part in yesterday session. This is a patient or child who is presenting with headache, fever, and vomiting, and it was diagnosed to be herpangina. Yes, it is actually the enteroviruses which is responsible for this particular condition. Enterovirus is it will cause these kind of lesions in the soft palate. So now coming to the next question, that is Kaposi sarcoma. I've already told about that. It is due to HHV8. HHV8 is, that is human herpes virus 8 is the previously called Kaposi sarcoma associated herpes virus. So now the next question, woman presented with dome-shaped warty lesions. You can see there are some umbilications or dimple at the center. This is due to, yes, it is actually due to Poxviridae, that is molluscum contagiosum lesion. Always remember molluscum contagiosum, you can have that inclusion body of molluscum bodies, and it is a sexually transmitted or disease which can be transmitted back through contact. So it's very spreading in nature. So many a times treatment which can be opted for is cauterization or electrical cauterization, etc. So that is a usual modality of treatment. Okay. So what is this type this virus which is usually appearing like it is seen also in swimming pool contamination. Yes, very good. This type of viruses wherein you can see the typical initial first Aryabhatta type of space vehicle. It is seen in which of the above virus? Yes, it is adenovirus which is actually having this kind of space vehicle type of appearance. Okay. So what about this slap cheek appearance with fever? Which viral infection will be responsible for this? Yes, it is the parvoviral infection, parvovirus B19. Always remember there are different viruses with characteristic days of, new numbered diseases. There are first disease, second disease, third disease, fourth disease, fifth disease. and sixth disease. So this is a disease which is usually classified into the fifth disease category. Sixth disease is not actually per se sixth disease, but it is sixth day disease. Okay. So usually first disease, these all coming under staphylococcal infection, then second scarlet fever, then third disease usually there are some sort of confusions. It is coming under streptococcal infections, etc. So you have to learn back that days of diseases, corresponding diseases. So try to learn about that. Parvoviral B19, I have told it is actually a disease, I mean virus, which is back DNA virus. So it can cause different kind of condition. This is one of the clinical condition which can be seen in parvoviral infection, that is erythema infectiosum. Other conditions are plastic crisis, transient plastic crisis, then erythroblastosis vitalis like appearance. So different conditions can be caused by parvoviral B19 infection. So this is a condition of slap cheek appearance in parvoviral B19 infection. So coming to the next type, my next question, that is which subtype of human papilloma virus which has the maximum chance of causing carcinoma cervix? Yes, it is the human papilloma virus 16 and 18, whereas the second option 6 and 11 stands for low risk serotype. 16 and 18 are the high risk serotype. So you can see different lesions which can be produced by this human papilloma virus. In a transient infection, they will not cause that much problem, but when it actually persists for a long duration, for any viral oncogenesis or any bacterial oncogenesis, the first and foremost criteria which has to be maintained is a long standing or a latent infection. So it is also applicable to in different viruses like hepatitis B, whether it is hepatitis C, or even in HIV or Epstein-Barr virus. Especially in Epstein-Barr virus, it can cause many amount of malignancies like nasopharyngeal carcinoma, then gastric carcinoma, Burkitt's lymphoma, non-Hodgkin's lymphoma, Hodgkin's lymphoma. There are ample amount of malignancies which can be caused by Epstein-Barr virus. So always remember this herpes group of viruses. They are notorious to cause latent infection or latency in our body. Just like what you hear about in HIV infection, this herpes viridae have this property. Similarly, do the human papilloma virus, which can also stay back in the as an infection for a long duration of period. So it will simply progress on to carcinoma. So we can classify it as CIM, L-cell and H-cell type of varieties, that is low risk and high, low risk mutation and high risk mutation variants. Okay. So coming to the next point, that is what is true about antigenic drift? Is it caused by influenza A, leads to seasonal epidemics, leads to pandemic, and arises due to frame shift mutation? Any idea? No, it is actually not due to frame shift mutation. Frame shift means actually it is a complete change of the 3 codons. So there are two different types of entities in case of influenza viral infection. One is antigenic drift and shift. So it is drift which is usually responsible for minor epidemics, but shift is the one where you see this frame shift kind of mutation or complete exchange of gene segments. So it is more common in shift is more common in A subtype influenza A, and drift occurs both in A and B, but it is only responsible for minor epidemics. Okay, but shift is more notorious. So back in 2009 H1N1 outbreak, they were all pandemics which was caused by the antigenic shift, not by drift. So the answer for this question is it is leading to seasonal epidemics. Okay. So this is actually answer for the question which I have answered about this thing back in the previous question. So this also I have given. This is the Warthin-Fingaldi giant cell, which is seen in case of Measles virus. You can see there is a single cell with a different multiple cells being coalesced into as a single cell with a giant cell appearance. Okay, so it's seen in case of measles. So what is the most fatal complication of measles? Yes, can anybody say what is SSP? Can you give the full form? No, it's not pneumonia. Yes, it's subacute sclerosing panencephalitis, as the Adra has slightly mentioned. So there are two different questions usually being asked. It can be confusing. Somebody has given the answer as pneumonia. So pneumonia will become the answer if the question was what was the most common complication of measles. So usually many a times the measles per viral infection per se will cause the person's immune system to drop to such a low level that he or she can get or the child may be prone for many other infection, especially respiratory infection. So the most common complication of measles viral infection is pneumonia, but the fatal complication, it is very rare, even though it is very rare. The most fatal complication is SSP because simply because of the reason that it is a slow viral disease. It will take many amount of time. We will not be able to detect it very quickly, and also it is involving our most crucial organ. Okay, that is the brain. So you can see there is the losing of this cerebral gyre. So this is due to the damage which is occurring due to the measles viral infection. So regarding the respiratory viruses, all are true except RSV is most common cause of bronchiolitis in infants. Mumps causes septic meningitis in adults. Measles causes SSP and EBV causes pleuritis. What is the false statement? Yes, it is actually EBV causing pleuritis. Even though I have told EBV can be responsible for many malignancies and many phenomena, but it does not cause any pleuritis. So the first answer RSV, you can see many a times when you are sitting back in a casualty every night, you will see some of the kids who are being taken by their parents and they are having difficulty in breathing with you. If you are putting your stethoscope over the chest, you will hear mild trepidation, and many times usually you will give hypertonic saline nebulization. It will be sufficient to clear out the respiratory syncytial virus infection. So it is a one commonest cause for bronchiolitis. Mumps, it is also a causative agent for aseptic meningitis. The term aseptic simply denotes that there is no visible pathogen or which can be cultured or isolated back in a culture plate, especially points for a bacterial pathogen. Measles, we have already discussed about SSP. Now coming to the next question, a newborn presents with PDA and cataract infection with which group of viruses is likely to be the cause? We have already discussed about that, rubella viruses. So there is a classical triad of rubella, which I've already told, cataract, cardiac abnormality, sensory neural hearing loss. There are other, of course, other manifestations like growth retardation, rash. But these are uncommon. I mean, these are not specific because many a times most of the congenital infections will cause all these kind of problems. Okay. So all among these are the mosquito-borne viral infections except. Yes, it is the Cassandra disease. It is actually a disease which is restricted back to the Shimoga district of Karnataka. Or nowadays we have seen many cases back in Wayanad. Recently we had a Zoom meeting where it was reported to have many cases being detected back in Wayanad. But we are mostly think it is actually a disease which is usually spread via the tick. Okay. So it's a tick-borne disease. So ticks are usually more found back in the forest region or in scrub or bushy vegetation like areas. So it's usually seen in forest areas. So nowadays it is actually a disease which is more appearing in urban setup because of the excessive deforestation. We are actually going back into their environment and building our own homes. So it can be notorious for them. And if a person, especially those who are living in close proximity to this forest and who are taking their cattle for feeding back into the deep depth of forest, they will usually carry back these sticks back to their home, and they can be a simple connection for getting Casanova forest disease. So it is a hemorrhagic disease, always remember, but though it is actually a self-limiting disease, there is nothing much to be done, but some cases can go wrong. Um, Now coming to next case, patient comes with a history of joint pain and fever for 1 week. For which the patient took NSAID and developed rash and hyperpigmentation on the nose. The catchy word is the hyperpigmentation. You can see the hyperpigmentation which is there in the nose. Just consider this was a disease which occurred back in 2006 in Kerala. Any idea? Is this answer B given for this question or previous question? I have not noticed. No, it's not dengue. Yes, it is actually chikungunya. Okay, so this is the classical sign which is seen in chikungunya infection called as chick sign, which is actually the hyperpigmentation, or it is due to the melanocyte proliferation which is actually occurring in the tip of nose. So we are seeing somebody with history of fever and joint pain and this classical chick sign. Whenever there is an outbreak of chikungunya going out back in the community, always go for a diagnosis of chikungunya. You can diagnose it using IgM antibody assay. Okay, so chikungunya was a disease which was there previously in our community, but in our country, but it was silent for some period of time. But later on, due to some mutation, especially the change at E1 position with alanine from at 226 position from alanine to align, it has become more powerful, and there was also more susceptibility for its vector, that is Aedes albopictus. So naturally it has increased the chance of outbreak of chikungunya. So we had an outbreak back in 2006 or 2006 2007 era. If somebody, if you are remembering, well and good. So coming to J, what is the role of pigs? Any answers? Yes, in J, pigs are actually acting as a amplifier. So this is a CDC class, CDC life cycle chart where you can see there are different entities like mosquito vector amplifying hosts are the Ardrich birds and pigs. Then it will again go through the Culex mosquito, and again will this cycle continue. But sometimes this mosquito, if they are biting dead end horse like human being, horses, etc., it can lead on to Japanese encephalitis. So this is not very common in our part of country, but Japanese encephalitis is single most commonest causative agent of encephalitis all over India, especially an encephalitis which is usually spread. In case of sporadic encephalitis, the most common causative agent was, I mean, is HSV, which was actually given in a sub question of, I mean, and option in the first question, which I have initially dealt with. Ardraid, I will give the. It's very difficult to pronounce. That's why. Okay. Clear, Noel? So we'll proceed to next question. So this is another phenomenon called as antibody dependent enhancement, which, and it is a feature which is seen in which conditions? Very, very important topic. Yes, it is actually seen in dengue hemorrhagic fever. So this is a little bit important topic. I will take little bit of time to explain about it. That is, you might have heard that dengue virus consists of different serotypes extending from dengue virus 1 to 5, usually 1 to 4 to be more easier. So many times whenever you are encountering with a patient in a primary dengue infection, maybe initially due to serotype 1 infection, naturally our body will start to produce neutralizing antibodies, and also this memory cells also will be produced in that particular case, but we will be protected from the same serotype infection for the entire rest of the life. But there can arise situations when we are getting infected in or in a secondary dengue infection with a different serotype. Our body finds it very closely similar, I mean closely similar to the original first serotype. So but still there are some differences, so body will start to produce new antibodies in order to neutralize the new epitopes of the different serotype. But one thing happens is our memory cells also find it very close to the previous infection, so it will again start to produce antibody which was intended to neutralize the first serotype. So nowadays, now what happens is actually the neutralizing antibodies which are being produced by the memory cells will go and block the action of the newly produced neutralizing antibody which was intended to neutralize the new serotype. So what happens in overall effect is the virus will go unchecked. There will be no one to protect the second serotype infection. So the virus will go haywire and it will go cause destruction around in all the body parts. Okay, so that phenomenon is called as antibody dependent enhancement. This is also applicable in case of SARS coronavirus 2 infection. Okay, so the answer is dengue hemorrhagic fever. SSP we have already dealt. SSS also we have dealt yesterday. This staphylococcal scalded skin syndrome. So in which of these vaccines we cannot administer the vaccine for? Yes, it is the yellow fever vaccine. Here I will discuss about what is actually happening back in egg inoculation. So whenever you are seeing a case of a fertilized egg, you can appreciate the different layers of a fertilized egg. This is the air sac where this all the respiratory air exchange will occur. This is the amniotic cavity, just like in case of our embryo also, it is similar. The amniotic cavity, amniotic cavity, which is outerly covered in the outer side by the allantoic cavity, which is much larger in size, and there is the yolk sac. And many a times you make utilization of these potential cavity, that is amniotic cavity, then the allantoic cavity, and much outer to this is actually the chorioallantoic membrane, or CAM. So this is the chorioallantoic membrane. So this chorioallantoic membrane is utilized for detection of pock forming viruses like smallpox and monkeypox or variola, etc. All these things can be detected by using chorioallantoic membrane inoculation. In case of amniotic cavity, it is potentially a smaller space, so we cannot go for mass production of vaccination. A much larger area is the allantoic cavity, so it can be simply used for vaccine production. So as I mentioned, CAM is for herpes viridae or pox virus or Rausa-Sarcoma virus. Leave Rausa-Sarcoma virus, more important is the herpes viridae and pox viridae. And amniotic cavity, we can go for influenza virus. But remember, influenza virus detection is done using amniotic inoculation, and vaccine production is done using the allantoic, much larger cavity. Mumps virus, avian adenovirus, they're all made use of this allantoic cavity. Yolk sac infection, you can go for rickettsia, chlamydia, herpes virus, etc. Okay. Now coming to diagnosis of polio, how can you do it? Yes, it is the detection of poliovirus in stool. You might have heard back in the SPM, you can go for AFP surveillance, but it is only for surveillance part. The main laboratory confirmatory diagnosis is usually done through the detection of poliovirus back in the stool. Okay. So poliovirus, remember, it is a disease, even though causing neurological manifestation, it is spread via fecal-oral route. So coming to Coxsackie virus, it causes all except which clinical condition? This hepatitis, Coxsackie has nothing to do with hepatitis. It causes all the other condition, acute hemorrhagic conjunctivitis, especially by Coxsackie A24. Then A7 and A9 variants will cause aseptic meningitis and hand foot mouth disease. Yesterday we have already discussed about that. So these are all clinical conditions which can be produced by Coxsackie A virus. So this also we have discussed yesterday, an image of a child. So I've told acute hemorrhagic conjunctivitis. It is caused by which enterovirus? This is also a repeatedly asked question. It is not actually enterovirus 71. 71 will cause diarrheal manifestation. But it is 70. You can remember, it's always a confusing thing. I used to remember this. Just think that this is a 0. Okay. 70. You will always confuse between 70 and 671. 71 is also an answer for another question. Okay. So that is diarrhea. So remember, it is a 0. I is appearing like a 0. So 70. It is 70, which is responsible for acute hemorrhagic conjunctivitis. Now, what is enterovirus 72 being reclassified as? Yes, it is actually the hepatitis A. Hepatitis A and E, both of them are fecal-orally transmitted viruses and they are non-enveloped viruses. So we cannot make use of soap and water for easy disinfection. Okay. Is there any sound problem from my end? Okay, thank you. So answer for this question is hepatitis A. Okay. So hepatitis, there is not much to say. It is spread via fecal-oral route. Not much time remaining. Okay. So rabies, I have already told. It is detected by a Negri bodies. This was the thing which I have told. This is a Purkinje cell, especially seen in cerebellar region, where you can see inside the cytoplasm, you can see eosinophilic intracytoplasmic inclusion body. These are typical of rabies and is pathognomic. It's not seen in all the cases, but if it is seen, it is pathognomic. So solvent of use of solvent or detergent destroys lipid enveloped viruses, which is still likely to be spread. I've already mentioned hepatitis A virus is A and E, both are non-enveloped. So it will be spread via detergent plasma, even though if you are using soap solution. Okay. So Australian antigen is which among this? HBsAg, HBeAg, HBc, and HBV DNA. Yes, it is actually hepatitis B, HBs antigen, not HBe, it is HBs. Okay. So this is a basic structure of a hepatitis B virus. It's always remember, it's a partially double-stranded DNA virus. So there is a reverse transcriptase enzyme activity in the DNA polymerase. Don't confuse. If you are simply seeing reverse transcriptase, don't go and answer HIV. They can trick you. Okay, so this virus with additional DNA polymerase enzyme with additional RT-PCR activity is, sorry, not RT-PCR, reverse transcriptase activity is seen in case of hepatitis B. In case of HIV virus, this reverse transcriptase enzyme is present per se like that. Okay, so don't confuse it with HIV. It is only seen in HBsAg. So then you can see these are the HBsAg. Different forms are there. This is a complete or den particle, tubular forms or spherical forms, and these are the HBe antigen. Then inside that there is the core antigen and with partially double-stranded DNA within it. So Reverse transcriptase is an RNA-dependent DNA polymerase enzyme seen in which of the virus? I have already dealt with that. Hepatitis B virus. You can say what is actually happening back in the hepatitis B replication. It is going inside, and in its intermediate form, there is one thing which is actually a clue. Sometimes they can give the life cycle or replication and identify the virus. If you are seeing cccDNA, that is covalently closed circular DNA, it is typical of the life cycle of hepatitis B virus. I'm having very restricted time, otherwise I would have explained the life cycle. So a nurse is actually presenting with hepatitis B antigen and hepatitis E antigen. What does it indicate? Anybody? Yes, it is acute infectious hepatitis, because hepatitis HBeAg is actually a marker of strong infectivity. This chart is actually present back in the textbook also. I will give the PowerPoint PDF. You can go through it. It's not much time to I mean, go through this side bit, but it is very important. Try to learn and mug up. The concepts are very easily given in this each of this particular situation. We are having HPSAG and HPC, HBE. So whenever there is a raised HBE, it is simply showing that there is high infectivity. Okay, and presence of anti-HBS is seen only in case of post-vaccination and recovery. So we all those people. Sir, answer for previous question. What about this? Yes, it is actually hepatitis B virus. It was discussed back in this question. That's why I didn't say more about the answer. It is hepatitis B. Okay, so back to this question, you can see anti-HPS, it is seen in case of recovery and post-vaccination status. So if it will be good if you are able to learn this thing. Most probably some question will be there based upon this chart. Okay. So what is the protective titer? If all those you who have taken vaccination for hepatitis B or completed vaccination, what is the protective titer required? Anybody? It is the 10 milli international. Always make sure the unit it is milli international unit per ml. The unit is very important. Milli international units per ml. Sometimes questioner can trick you. Okay. So it is 10. To be more precise, it is 12 milli international unit. Always remember one fact. If you are having some protective titer more than 12, once in your life, if you are not becoming immunocompromised at any point of time, that particular titer, even though if it is going down in subsequent or future life, it can be taken as protective, because our memory cells will immediately kick back into action whenever you are getting a subsequent exposure. So keep that in mind. So a 50-year-old male patient is actually presenting with cutaneous vasculitis, proteinuria, and cryoglobulinemia with glomerulonephritis. What is the most appropriate test to come at their diagnosis? Any idea? It is C, that is anti-HCV OD. So this is a typical extra hepatic manifestation seen in case of hepatitis C viral infection, wherein you can see cryoglobulinemia and glomerulonephritis along with subsequent proteinuria and vasculitis component. Okay, so this is an usual question which is asked for AIMS examination, etc. So what is the chance of hepatitis virus? Which hepatitis virus actually has the chance of 3% transmission through needle stickage? Yes, it is hepatitis C virus. So usually it is 30% in transmission risk for hepatitis B virus, and 3% for HCV, and 0.3% for HIV virus. So remember, whenever you are sustaining, I hope all people do not sustain any needle stick injury, but still, if you are sustaining a needle stick injury, don't be frightened about HIV. So chance of transmission is very, very, very low. That is only 0.3%, but you can acquire hepatitis B viral infection, which the risk is around 30%. For the answer of this question is hepatitis C virus. Can you repeat the value percentage again, sir? I didn't get you, Dr. Roshni. Yes, it is HIV. HIV is 0.3 percentage. HCV is 3 percentage, and hepatitis B is 30 percentage. Is this one? Is it this one? Cryoglobulinemia you want? Yes, it is actually HCV infection. So naturally, the answer for that will be anti-HCV antibody. Are you clear now? Because HCV is an infection which can present outside the hepatic system as this cryoglobulinemia. Yes, hepatitis B is 30 percentage. There is 30 percentage risk. So if you are considering yourself, or if you are sitting back in a casual, if you are doing a surgical intervention for any patient, and you are intervening such 100 patients who are it's supposed to be HCV positive, sorry, hepatitis B positive, there is 30%, in 30 percentage of, or 30 cases, you can get infected. That is the concept. Okay. So there is 30 percentage risk in hepatitis B, 3 percentage in hepatitis C, and 0.3 in HIV. Am I clear? Okay. So now next question, that is hepatitis B virus is a defective virus. It requires its helper, that is usually hepatitis B virus for dash. Yes, it is the envelope protein which is actually given back in the diagram itself. This envelope, that is hepatitis B HBsAg envelope, is being shared by the hepatitis D virus. So it's as mentioned in the heading of this diagram. It is the most severe form to get because hepatitis D can either be as a co-infection or a super infection. So if it is becoming as a super infection, it can be very deadly. Okay. Now, next question. With which of the following viral infections in pregnancy is the maternal mortality the highest? Yes, it is hepatitis E viral infection. For those who are not aware or find it very difficult to learn about that answer, remember there is a enlarged abdomen in case of pregnancy. So enlarged E stands for hepatitis E. Okay. So HIV-1 target binding site is which among the following? Yes, it is GP120, that is glycoprotein 120 and 41. Remember this, the question is HIV1. If it is HIV2, it is different. It is GP108 and GP36, but that may not be usually asked for your question. Sometimes they can ask in names or GPMR. But for HIV1, the target binding site is glycoprotein 120 and glycoprotein 41. Okay, using the core binding receptors, that is CCR5 and CCXCR4. So those patients who are actually Caucasians lacking the CCR5, there is one typical mutation called as delta 32 mutation. It's called as delta 32. I will write about that thing in the chat box. Delta 32 mutation. So in such patients, if it is homozygous for, heterozygous, they will be some parts susceptible only for the HIV infection. And those patients who are heterozygous for delta 32 mutation, if they are having both the alleles, they will never get HIV infection. So this is usually seen in Caucasians. Okay. So I think you might be aware about this thing. HIV infects which of the following cells? It is T helper cells. Okay, it will go and bind to the T helper cells. It will cause the destruction of T helper cells, and finally it will cause two different manifestations of HIV. Whenever you acquire an HIV infection, it can progress through different states: acute HIV infection, symptomatic stage of clinical latency, and then the persistent generalized lymphadenopathy, and finally will end up as a AIDS-related complex manifestation, wherein you will see multiple opportunistic infections. So this is one among the opportunistic infection, an HIV patient complaining of visual disturbances with bilateral retinal exudates and perivascular hemorrhages. What could be the causative agent? Any answers? Yes, it is cytomegalovirus retinitis. You can see retinite involvement with patches on the fundus. Okay. So, which of the following is an opportunistic organism in AIDS? Which parasite? No, it is not as. Yes, it is Strongyloides cercoralis. So it is a rapidly formed larva. You can see back in a stool wet film examination. So this is typically seen in case of as an opportunistic infection in AIDS. Okay. So what is the most common organism causing diarrhea in patients who are ingested shellfish? So yes, it is actually the norovirus. I find this thing can be asked as a question because we had many noroviral outbreak recently. So sometimes this can be asked. Remember, noroviral infection is seen in case of adults, whereas in case of pediatric age group, it goes for rotaviral infection. Okay, remember previously norovirus was called as Norwalk virus. Okay. Then the virus causing acute respiratory syndrome, distress syndrome, this thing I feel like will not ask because everyone is actually aware about this thing, coronavirus. So this is not respiratory syncytial virus, it is coronavirus. ARDS is one of the complication which we had in the initial part of first waves of corona, first and second wave of coronavirus. So what is prion? It's actually a protein, as you have rightly mentioned. There are two different structural formulations: PRPC, which is the initial normal protein, and the modified version, that is PRPSC. Always remember, prion is a thing which is very highly resistant to routine sterilization procedure. We require autoclaving at an additional higher temperature of around 134 degrees Celsius, or will require higher concentrations of sodium hypochlorite solution or sodium hydroxide solution in order to neutralize prions. So whenever we are seeing any patient who had underwent a prion surgery, who had been prion positive, and any surgery, surgical equipments have to be dealt appropriately. Okay. So this is another thing, antifungal. So we are slowly moving on back to the mycology. So amphotericin B, it's actually an agent which attacks which type of cells? Which part of fungus? No, it is not cell wall, and fungus usually have the cell membrane. So it is on the cell membrane, it is being going and creating its action. Okay, so this is one another combination. It is given amphotericin B is highly toxic for our kidneys. So we usually give dose adjustment using liposomal components. Okay, so it is called as ambisome. So what about this? This is Candida albicans. It belongs to which group of fungi? There are different groups. Yeast like mold or filamentous fungi. Yes, it is a yeast-like form. Yeast usually, simple yeast will usually look in a spherical form, but in case of Candida albicans, there is, you can appreciate different pus cells and this budding yeast cells with the hyphae, pseudo hyphae. Okay. So which of the following among these is the yeast? Yes, it is the cryptococci. Cryptococci will cause these kind of yeast lesion. This is the Candida albicans. Candida albicans is another yeast-like thing. The answer for this thing is the cryptococcus. Okay. So this is a Seborrhous dextrosagar culture with olive oil overlay, which is used for, diagnosis of seborrheic dermatitis. It is seen in, it is used for diagnosis of which condition. Yes, it is a Malassezia furfur, wherein you will see the character is spaghetti meatball appearance. Okay, spaghetti meatball appearance in Malassezia furfur. It can lead on to dandruff. Okay. So this, a female had a thorn prick 5 years ago, and she presented back with some verrucous lesions like this. And upon wet wound examination, you have seen some uh, thing with septations in between. Yes, it is not sporotrichosis, it is chromoblastomycosis. I know it. You have confused with the terminology thorn prick. It was actually intended to confuse those students, because thorn prick, simply if you are going by that particular thing, you will go for the answer of sporotrichosis, keeping in mind of Ross Gardner's disease, okay, or sporotrichosis. But whenever you must remember about one fact, many fungal agents usually only will come back due to pricks with the vegetative matter. Whatever be the fungi, it will be using with usually due to the prick with the vegetative matter. So you can see here the classical bodies which are seen is copper penny bodies, or it is also called as the chromoblastomycosis bodies. Okay. So sclerotic bodies or muriform cells. There are different names. So this is typical, and you will not see any verrucous type of lesion. It is a one of the kind of lesion which is produced in case of chromoblastomycosis. In sporotrichosis, one question is actually upcoming here, and you will identify how will you get an idea whether it is sporotrichosis or chromoblastomycosis. Okay, so this is another question, which what kind of fungal spore is this? Yes, it is arthrospore, wherein you can see coilized hyphae with square like things. That is typical of arthrospores. It can be seen in case of Coccidioides immitis, etc. Okay, Coccidioides immitis. Remember, it is a biosafety level 4 pathogen, dangerous pathogen. Okay. So, which among the following is not a sexual spore? No, it's not ascospore. It is sporangiospore. Sporangiospore is an asexual spore. Orangiospore, conidiospore, these are all coming under asexual group of spores. So they actually simply spread. Sporangiospores are seen in zygomucorales, wherein just like mucor, rhizobos, etc. When they rupture, they will spread away the spores to distant places, wherein you can produce progeny. So it's not an asexual type of spore. It is an asexual type of spore. The answer for this question is sporangiospore. Okay. So next question, 45-year-old male patient presenting with low-grade fever and separated granulomatous lesion of the skin, and he gives history of North American travel. That word is important. I mean that location, North America, and there is left lung consolidation with hilar lymphadenopathy. And another thing you have to remember is at 37 degrees Celsius, it is showing yeast cells with single broad-based buddings. That keyword is broad-based budding. You can see broad-based budding. So B stands for broad-based budding. B stands for blastomycosis, not histoplasmosis. It is this word which is key, North American blastomycosis, wherein you will see broad-based budding standing for blastomycosis. Okay. So this was the question which somebody had actually mistaken. So this is a Ross Gardner's disease. Following traumatic inoculation into the skin, you will see the Sporothrix shenghi infection. Okay, Sporothrix shenghi infection. So it is the Ross Gardner's disease. So you will identify it mainly using the pattern of lymphatic involvement. So whenever the lesions, if you are closely observing, you can appreciate it is going through a lymphatic pattern. So whenever you are seeing this history of copper penny bodies and verrucous or ulcerative kind of lesion, go for the diagnosis of chromoblastomycosis. Whereas in all other aspects, whenever you are seeing lymphatic pattern, go for Sporothrix shenghi infection. Okay. So another question, an HIV positive patient coming with pain in the hip region, aspiration done showed multiple monocytes and macrophages with yeast-like organisms in the 4 to 6 micrometer size in the cytoplasm. You can see multiple involvement, liver involvement, lesions over the body parts. Then in case of oral cavity, then lesions in the body parts. What is the commonest causative agent? Yes, it is histoplasmosis. It is this thing. If you are seeing that broad-based budding, go for blastomycosis. Whether it is North American region, go for blastomycosis. There are different species: blastomycosis, dermatitis, Gill Christie, like that. But this case, multi-system involvement, especially reticuloendothelial, like as in case of Hendrick fever, reticuloendothelial infection, involvement like in spleen, liver, etc. Go for the diagnosis of histoplasmosis. Okay. So Raynaud-Brown phenomenon is seen in which disease? Yes, it is seen in Candida albicans. Candida albicans. So you can see this germ. It's also called as the germ 2 test. It is positive for Candida albicans as well as Candida dublinensis. So if there is no actual constriction at the point of arise, point where the budding is arise. Okay, hyphae arise. So if it is there, that is not a true hyphae, it is only a pseudo hyphae. So if we are seeing this kind of A type of lesion, it is suggestive of Candida albicans. Another patient, an HIV patient with complaints of headache, neck fever, stiffness and weakness, suspected meningitis and lumbar puncture, revealed no organism. What could be the possible organism? Yes, it is a cryptococcal meningitis wherein you can see the enhancement of the peripheral leptomeninges. Okay, so cryptococcal infection. So what is capsule of cryptococcal neoformans is best seen by which preparation? Ramstein, Indian grain, Gemsa, or methenamine silver? No, it is not methenamine silver. It is by India ink preparation because it is a capsulated organism. You can detect the negative staining. This is the black areas and the capsule will create haloing. Here you can appreciate the budding of cryptococcus. Okay. So in a patient with corneal scraping, we revealed a narrow angled septate hyphae with this classical appearance, which is this particular fungi. This was an Ames question. Yes, it is caused by Aspergillus. This is a typical Aspergillus fumigatus. Remember, fumigatus, the conidia will be always pointing just like fumes or fumes from a can agarbati, etc. Okay, so it will go up. So if it is actually pointing upwards only, the conidia, if it is present upward also, only, it stands for Aspergillus fumigatus. It's not requirement is there for you to learn the species. Simple Aspergillus is enough. Okay. So most common fungus causing orbital cellulitis in a diabetic patient. Yes, it is mucormycosis, more commonly called as the misnomer, that is this black fungi. It's not an improper term to be used because it's not an ideal black fungi. Black fungi are usually the demeticious fungi which has black color in their hyphae. So this is not an thing which is coming under black fungi. But always remember, whenever you are seeing a diabetic patient, it is mucormycosis in the nose and also in ear, it is the pseudomonas infection. So remember, yes, it was heard back in the COVID-19 initially. So it was usually said as black fungi only due to the lesion, type of lesion which is caused by the mucormycosis. Mucorales is actually a fungi which is very much angio-invasive. So what they will do is this hyphae will go and penetrate back into the blood vessels and obstruct any blood supply back to the distal organs or distal parts. So the site of infection will be usually becoming gangrenous in nature. So that was the reason it was called as black fungi as in the layman language. But for a clinician, you should never use it as black fungi. Always say it as mucorales or mucormycosis. There are different other fungi called as black fungi or demeticious group of fungi, but topic is actually beyond the scope of our time. Okay. So what is the drug of choice of pneumocystis irovetsi? It's called as irovetsi, not giro. So this is a classical crushed ping pong ball appearance. Can also be asked for your question. Yes, it is cotrimoxazole, which can be used for the treatment of pneumocystis irovetsi infection. It is seen as an opportunistic infection, especially in HIV infected patients. So coming to the parasitology section. So auto-infection is seen in all of the following except is seen in, I mean, it's not seen in Hymenolapis diminuta. Yes, in I didn't complete actually. It was I was interrupted back by the black fungi. So remember, in diabetes infected or uncontrolled diabetes, any patient you will see in different kind of infection. In nose it is mucormycosis, and in ear it is pseudomonas infection, that is otitis externa. I repeat, it is a repeatedly asked question. In any diabetic patient, it is mucormycosis in case of nose infection and pseudomonas in case of otitis externa or ear infection. Okay, got it. So auto infection, the answer is Hymenolapis diminuta. It is Hymenolapis diminuta is actually not, spread by auto infection. All the rest, that is the mnemonic for auto infection is chest, CHEST, where C can be Cryptosporidium capillaria philippensis. Then H stands for Hymenolapis nana, E stands for Enterobius vermicularis, S stands for Strongyloides stercoralis, and T stands for Tinea solium. Okay, auto infection of Tinea solium. So this is a mnemonic for auto infection. So this is actually a Hymenolapis nana, egg of a Hymenolapis nana, wherein you can see polar filaments and polar thickening. So which of the following parasite can enter through intact skin? What is C, sir? I didn't get Hymenolapis nana. You asked for? Cyril, you asked for Hymenolapis nana? A C in chest pneumonia, because it is Capillaria philippensis. Capillaria philippensis. There are two letters for C. One is Capillaria philippensis and another one is Cryptosporidium parva. Both of them can be spread via auto-infection. I think more important is Cryptosporidium. You can remember it as Cryptosporidium parva. Cryptosporidium parva, Hymenolapis nana, Enterobius vermicularis, S for Strongyloides cercoralis, and T for egg of Tinea solium. Okay. Okay, coming to which of the following parasite can enter through the intact skin? Anybody? Yes, it is the Strongyloides cercoralis. Strongyloides cercoralis can enter through the skin also. Okay. So small amount of thin stools with mucus mixed mucus and blood mixed stools. So it is not adherent to the stool. So what kind of organism is responsible for this particular clinical condition? Anybody? Yes, it is not. No, it is not Giardia lamblia. Giardia lamblia does not cause any blood-stained stools. It is Entamoeba histolytica, which can be leading on to this dysentery type of manifestation. So dysentery can be seen in bacillary ulcerative colitis, tuberculosis, etc. Okay. So ingested RBCs are seen in which of these pathogen? Yes, it is seen in case of Entamoeba histolytica. This is an wet film examination of Entamoeba histolytica, where you can see the ingested RBCs in situ. So what is the number of nuclei which is present in the mature cyst of Entamoeba histolytica? Yes, it is 4. You can see, as in this diagram, you can see 4 nuclei which is present in the cyst of Entamoeba histolytica. So Naegleria fowleri is found in which place? Yes, it is the warm fresh water. Those persons who are going for an open pool in the warm fresh water, they will be very much at risk of Naegleria fowleri, which can lead on to primary amoebic meningoencephalitis. So, a patient who is using a contact lens recurrently with an unhygienic situation can predispose him or her to which of these infection? Yes, it is acanthamoeba keratitis which can occur. So this is an acanthamoeba with pseudopodia. These are the pseudopodia. Okay. So identify the parasite. Yes, it is Giardia lamblia. It can be responsible for foul smelling the stools. So many times one specific test is there, enteric test, enteric test or string test, wherein you will the patient is allowed to swallow back a capsule with thread which is being attached, looped over the particular capsule, and at one other end is actually attached back to the cheek. So it is actually intended to take back the trophocytic forms from the duodenum where the parasite usually resides. Okay. The right name of that test is string test or enteric test. Okay. Romanas sign is seen in which of the following condition? Yes, it is trypanosomiasis, that is especially trypanosoma cruzi, that is Chagas disease. Okay, this is classical subcutaneous edema which is occurring in the upper unilateral upper eyelid. So, what is the disease which is caused by Radovid bug? Yes, it is the same, that is Chagas disease. Okay. So, Winterbottom sign is sign in which of the clinical condition? You can see some enlarged posterior cervical lymph node. This is seen in which clinical condition? Yes, it is in African trypanosomiasis, West African trypanosomiasis. Okay. So, that is about Winterbottom sign. Vector for Cala azaris is this thing. What is this thing? No, it's not Tsetse fly, it is the sand fly. Okay, it is the vector for Cala azar. Tsetse fly is actually responsible for or transmission of leishmaniasis. Sorry, not leishmaniasis, the sleeping sickness, African sleeping sickness. Okay. So this is Colpitis macularis, that is the cervical area. So you can see a classical strawberry appearance, also called as Colpitis macularis. It's seen in case of Trichomonas vaginalis infection. Okay. So in Gardnerella vaginalis infection, it is usually the bacterial vaginosis. Okay. So true about peripheral blood smear of malaria are all except. Yes, it is the enlarged erythrocytes in Plasmodium falciparum, because in Plasmodium falciparum, the gametocytes are so small, so they will not usually lead on to enlargement of erythrocyte, but it is enlarged in case of Plasmodium vivax. Okay. So next question. The Plasmodium species known for relapse in malaria. Yes, it is Plasmodium vivax and ovale. In vivax and ovale, it will usually go into a hypnozoitic stage in the liver, which will usually come back after some point of time. So that is responsible for the relapse in Plasmodium vivax and ovale infection. Okay. So infective form of mosquito in Plasmodium falciparum. Remember, it is an infective form of mosquito. It's not trophocyte. It is a gametocytic stage which is actually responsible for the infective form of mosquito. For human beings, it is porocytes. So recrudescence is seen in which infection? I mean, which clinical condition? It has got cut off. It is a reappearance of sexual stage parasitemia after treatment. Last option is reappearance of sexual stage parasitemia after treatment. Image cut type. Answer എന്താണ് ഇതിന്റെ? അതല്ല. It is resistance due to resistance of treatment. Resistance to treatment. Whenever these bugs are actually resistant, they will come back after some time. Okay. So cerebral malaria is caused by which of the following? Yes, it is the Plasmodium falciparum, also called as the black water. It can also lead on to black water fever due to plugging of the capillaries. Okay. So Maltese cross appearance is seen in case of Babesia microti. Okay. Babesia microti. So you can see classical Babesia microti lesions, multi-sclerosis. So Fabin-Feldman dye test is used for which of the pathogen? Yes, it is toxoplasmosis. I usually found it very difficult to learn back in my PG time. ഞാൻ അത് പഠിച്ചത് ഗുണ്ട സാബു എന്നാണ്. ഗുണ്ട സാബു. ഓക്കെ. അപ്പം സാബു എന്നുള്ളത് സാബിനും ഗുണ്ട എന്ന് ഉദ്ദേശിച്ചത് ടോക്സോപ്ലാസ്മ ഗോണ്ടിയുടെ ഗോണ്ടിയാണ്. ഗുണ്ട സാബു. ഓക്കെ. Just for fun. Don't take it seriously if anybody has some name related to sabu. Okay. So cat acts as a reservoir in which of the following? Yes, it is the same Toxoplasma gondii, wherein it is actually spread through the cats. The post-renal transplant patient presenting with diarrhea after 3 months, it was showing a spherical organism. Can anybody name what is the type of organism? It is a acid-fast, modified acid-fast stain which is being shown. We are seeing, yes, it's not a Clostridium difficile. It is Cryptosporidium hominis. Cryptosporidium. Okay, you can see approximately around 7 micrometer in size, and this is Cryptosporidium infection. Okay, so 25-year-old male patient presented with diarrhea for 6 months, and it was found to be acid fast with 12 micrometer in diameter. Now the size is little bit more bigger. What would be the causative agent? Not Cyclospora. Cyclospora is more bigger. Is cystisospora. Okay, so you can learn this chart from back from your textbooks. It's given there. Remember, there is presence of autofluorescence in case of cyclospora and cystisospora. Okay. So operculated, this is operculum, just like a mouth opening. It is seen in all of the following eggs except for which? Yeah. Yes, seen. It's not seen in Cyclospora. It can range up till a size of 22 micrometers. From 12, I mean, you are right, more to, but it is usually in a median size of around 20 to this 33 micrometer. Oh, actually, I got it wrong. Oh, thank you, Noel, actually, for showing me. I got it mistake. It is cystisospora which is larger. You are right. It's my mistake. Okay. Thank you. So now coming to next post-renal transplant patient with diarrhea after 3 months, which is showing 2 to 6 micrometer. So this thing, what about this thing? Yeah. Operculated X answer. Sorry. Yes, operculated is, any idea? Yes, it is Hymenelolepis nana. We will not see Hymenelolepis nana with operculated. It is for Hymenelolepis diminuta. You will see this operculated type of X. Okay. So which of the following is the most central nervous system parasitic infection? We have already discussed about that initially. Any idea? Yes, it is the neurocysticercosis. So you can see these are the calcified lesions which can be seen inside the brain parenchyma. So it is the most common cause of sporadic parasitic infection which can lead on to epilepsy. Okay, remember that point. It can also be asked in a question. Okay. So this is a typical water lily sign. You can see something is actually floating back in a cavity of liver. Yes, it is the hydatid disease which is caused back by the Echinococcus granulosus. This is the endocyst layer of the this particular cyst which is being shedded back onto the fluid. Okay, so it will typically look like a water lily seen in, it's a radiological finding seen in Echinococcus infection or hydatid disease. Okay, so skin test useful in hydatid diseases. Yes, it is the Cassoni's intradermal test. Just like in TB, what you see in case of superficial infection, this is same as in Cassoni's test. Okay. So intermediate host for hydatid diseases is also called its name. It is dog's tapeworm. Yes, you are right. It is the dog which is actually the intermediate. I mean, sorry, no, it is the dog which is the main host, and man is actually the intermediate host for this particular clinical condition. Okay, so it is the dog which is the definitive host, and the man is the intermediate host. So answer for this question is man. Okay. So what is the second intermediate host to Diphyllobothrium latent? This thing actually, this host thing, it's difficult. It should learn and mug up because they can usually ask this thing. So question was actually second intermediate host. The first intermediate host you have correctly answered as cyclos, but when the question comes as second intermediate host, it is the fish, freshwater fish, not cyclops. Okay. So they can trick you by that word. So coming to the which of the following egg, which I have already shown, it is standing for Hymenelepis nana. Okay. So which organism can be isolated from stool and sputum? Yes, Paragonus westermani. It is the lung fluke. So in its life cycle, you can see it is actually coming back through our respiratory system, and it is later on ingested back into the system, body. Okay, so it is a thing which can be seen back in stool as well as in sputum. Okay. So coming to the next question, ova in stool are not of diagnostic significance in which of the pathogen? Any idea? Not ankylostoma or this thing. Is strongyloids. Yes, no, you are right. Strongyloids. In strongyloids, it is actually ovoviviparous this parasite. So whenever the time this, I mean, egg is actually passed back to the stool, it will immediately hatch out to become the rhabditidiform larva. You can see the stool sample with the rhabditidiform larva in it. Okay, so this is a pathogen wherein you cannot always see ova in the stool, so it cannot be diagnostic. So what is the cause of this phenomenon called as larva currents? Worm is seen. Yes, Cyril, I didn't get you. What you have asked? Worm is seen. Yes, larva currents. Also, the answer is same. That is Strongyloids stercoralis. This it's different from larva migrants. Larva currents is cutaneous and in a higher. I mean, the parasite will migrate in a higher speed. Okay, so this usually seen in case of Strongyloids stercoralis. This ankylostoma, especially the non human ankylostoma like caninum, ceylanicum, etc., are responsible for the so-called larva migrates. Okay. So identify the organism from its egg. No, this is an egg wherein there is no proper bile staining. Yes, it is standing for hookworm egg. So the best answer possibly is a Necator americanus. You by just by looking at the egg, you cannot come at a conclusion, but this is an egg for Necator americanus. Okay. So a child with 3 years of age presents with weakness and loss of blood. So what is the most probable causative agent? Yes, it is a hookworm infection. Remember, hookworm is actually infected by usually by through skin penetration, not by ingestion of eggs. Okay. So these are the skin penetration site where you can see lesions. So X of which of the following parasite cause intense pruritus in perianal skin? Yes, it is by Enterobius vermicularis. You will use NIH swab for collection of the eggs. So what about this parasite? How is it acquired? This is the egg of a whipworm, that is Trichuris trichura. So it is actually transmitted by the ingestion of egg contaminated in the water. Okay. So Mayer-Konar syndrome is a synonym for which of the following condition? Any idea? Yes, it is the synonym for tropical pulmonary eosinophilia, wherein you can see excessive eosinophilia due to filarial worm infestation. So, egg of all of the following helminthic worms float in a saturated salt solution except for which of the following? This is the egg of Taenia solium. So there is a mnemonic stuff, sings and feather floats. Okay. So I will give this in the PDF. This S stands for Frongeloids Taenia, then unfertilized egg of Ascaris fasciola hepatica. These all sings, and those floating are the fertilized eggs of Ascaris, Enterobius, Ankylostoma, then Trichuris and Hymenelepis. Okay. So the image depicted below belongs to which of the following pathogen? So actually given back in the table, yes, it is Brugia malayi. You can differentiate. Always remember in Brugia there is B. Remember B for bi. So there will be two nucleus at the tip, and the headspace is twice as long as it is broad. You can identify the other parasites. Other things by this tabular column. Okay, Loa is another parasite which I will be coming now. So this, what is the causative agent of this lesion? Yes, it is loa. It is a calabar swelling. It is caused by the loa, which is a filarial kind of filarial worm, which affects the soft tissues. Okay, Bushraria bancrofti and Brugia, it will go and affect the lymphatic system. So cutaneous larva migrans is caused by the following species of Ankylostoma except. Yes, it is Ankylosoma duodenale. It's a human pathogen, so it will not go and cause the larva will not go and wander here and around. It properly knows the route and place where it has to go and mount the infection. For all the other, these are not infectious agents of human body. Okay, so most common lactose fermenting organism that cause UTI in a patient with catheter in situ. To general microbiology, I am about to finish my topic. A few slides remaining. Yes, it is Pseudomonas. Pseudomonas is the pathogen which is responsible for biofilm formation. So it's notorious. You can see greenish pigmentation, especially in case of Pseudomonas, blue-green pigment in Pseudomonas aeruginosa. It is typical. This is a nutrient agar plate which is showing diffusible green pigment. Okay. So a man presents with to the STA clinic with urethritis and urethral discharge and numerous pustules but no organism. And the culture is negative on routine laboratory medium. What could be the possible agent? No, it is not Haemophilus ducrei. It is Chlamydia trachomatis. It is a thing, an organism which cannot be easily cultivated and identified. Its slow, slender, cannot be visualized also in microscopy. So it is a causative agent for this particular clinical condition. More apt one is Chlamydia trachomatis. In case of Haemophilus ducrei, we will see ulcer. Treponema also we will see ulcer, but nothing is mentioned about that. Okay. So time for lunch. Dinner. There's formed poisoning that is which is already there in the food is seen in which kind of organism involvement. Yes, it is staphylococcal infection. Okay, staphylococcal, I mean, is usually seen, but the question is all except media. Not Clostridium, it is E. coli. E. coli diarrhea or poisoning will always occur in a time period of more than 24 hours. So all the other Staphylococcus or Clostridium botulinum or emetic toxin of Bacillus is all these things can cause manifestation within a period of around 6 7 hours, 6 or 7 hours. Okay. So in the gut, anaerobic bacteria outnumber the aerobes by what proportion? Any idea? Yes, it is 1,000 times more. Always remember, we are actually a moving population of bacteria. So our number of bacteria which is actually residing back in our body is much, much more than the human cells indeed. Okay. So organism most likely associated with ventilator associated pneumonia. Yes, it is Acinetobacter baumannii. Acinetobacter is a notorious pathogen for multi-drug resistance. So it is most commonly associated with ventilator-associated pneumonia. Okay, you can see coccobacillary, gram-negative coccobacillary appearance. Okay. So biosafety grade 3 precaution is practiced in all of the following organisms except no, Mycobacterium tuberculosis is the thing which requires grade 3 class. It is human influenza virus. It is only a grade 2, I mean, a virus which can be opened in back in a grade 2 laboratory. I mean, okay, so biosafety level 2 is only required. For all the other pathogen, it is very deadly and we should open only in a biosafety level 3 precaution laboratory. Okay. So this is an image of a BSL-4 laboratory wherein you can see the people are working in a spacesuit like jacket and something is actually dropping back from the roof. These are the positive airway systems which are being connected to the patients. Okay. So I mean, sorry, not patients, the laboratory personnel. So whenever any pathogen, if at all they are trying to get an entry into the suits, it will be expelled back by the positive airway pressure. So it is very tedious for them to work back in these laboratory. They have to carry away these connecting wires to their jacket, and then only you can, I mean, remove and reattach with another wire in the nearby area. So it's very difficult for them to handle with this. This facility is actually available back in National Institute of Virology, Pune. Okay, that is a maximum containment laboratory in India. So next question. Before that, I will just show about. I mean, this you can read from the PDF. These are the various biosafety levels. 1 to 4. 4 is for deadly pathogens like Ebola virus, smallpox, Nipah virus, etc. 3 for tuberculosis, SARS-CoV-2. You can actually do it back in biosafety level 2 also. Okay, so you can learn this from the PowerPoint. The single most common cause of pyrexia of unknown origin is, you have to take into consideration our country, which is very much endemic for one of this particular clinical condition. Yes, it is Mycobacterium tuberculosis. We are surrounded in all aspects by the pathogen. Okay. So which of the following is the choice of antibiotic in a bedridden patient in ICU with COTI, that is catheter associated UTI, and VAP, that is ventilator associated pneumonia in India? Yes, no, it is not third generation cephalosporin, because most of the time these patients with the COTI and VAP, we will find them to be beta lactamase inhibitors. So we have to give a combination of beta lactam along with beta lactam inhibitors in order to prevent such infection. So best possible action is, and answer is best beta lactam with BL BLI combination. Okay, BL BLI combinations. Okay. So most common catheter-related bloodstream infection is due to which of the following pathogen? Any idea? Yes, it is actually catheter-related diseases are mainly due to coagulase negative staphylococcus. Okay, that so you have to always, yes, it is of epidermidis. Sure, make sure that you are not getting, I mean, you are not taking samples in an improper way, so that you will get confused whether it is a skin commensal or you are dealing with a true pathogen indeed. Okay, so it is answer for this question is coagulase negative staphylococcus. Okay, which could be usually Staphylococcus epidermidis. So, according to the Biomedical Waste Management Guideline 2016, which is the bag which can be used for incineration, or the what I mean, the contents in which bag can be used for incineration. No, it is not red bag. Red bag contains all the plastic materials. We cannot incinerate. It is very toxic to our environment. It is the yellow thing under which we will put our face mask, then tissues, bodily parts, then clothes, etc. I mean, clothes in the sense the dressing materials, etc. Soil dressing materials, etc. So all those things in yellow bag will can be used for, I mean, and sterilized using incineration technique. So this is the basic thing. You can get that thing. I mean, read that thing from the PDF. Okay. So this is the sign or symbol used for which of this following condition. Yes, it is a radiation hazard sign. There is another sign for the biohazard also. Go through that thing in the internet. That is also very important. They can usually ask any of these things. Okay, then coliform count is done by which method? Yes, it is using the multiple tube method. So you can see that we use multiple strength of double strength McConkey broth in order to identify the colony count. So the presumptive colony count is actually diagnosed using this multiple tube method, and the differential counts, which is actually made through the Eichmann test. Okay, so this was my last PowerPoint question. So with that, I'm giving you, wishing you all the best for your examination, and hope you become a good star in the future life. Okay, thank you.
Yes, good evening, sir.
Good evening, sir.
Thank you for Sir Randu Usam. You have taken all the pains to teach our young brothers and sisters. So, on behalf of IMA PEPS and Junior Doctors Association, I my personal thanks to you for coming over the last 2 days. You have been so busy, and continuously you have been teaching all recent MCQs. So I hope it has been help to everybody who attended this class.
Sir, 1 second, sir. Actually, one candidate actually asked for some clarification.
Yeah.
DNA viruses. Okay, DNA virus. You can remember it by the code HHP PAP. HHP PAP. I will write. Okay, so under this first H comes as Hepatna viridae, then second H comes as herpes viridae, then P comes of Papua virus, under which polyoma and parvoviridae comes, then then adenoviridae also comes, then Papua, polyoma, parvoviridae, all these things, three things. Okay, this much is the DNA viruses, and all the rest of the other viruses are coming under RNA group of viruses.